Well, good evening, everybody, and thank you very much for joining this webinar session. Tonight, we will be hearing about the recently expanded cervical screening test sample collection options and reviewing clinical management of women at intermediate risk in the National Cervical Screening Program. I'm Sandy Vincent from the PHN Education team, and I'm joined tonight by our two presenters, Denise Lyons and Dr. Sally Sweeney. Before we begin, I would like to acknowledge the traditional custodians of the land that we live and work on and pay my respects to their enduring culture and contributions to this vast region. I've just got a few things to let you know, that this session is being recorded and that the recording will be available at our PHN website on the Education Library in a few days. If you do have questions during the presentation, please use the questions box, which you will find in your panel. If you click the drop-down arrow, you can write your questions into there, and we'll review those questions at the end of the session. An evaluation will come to you directly after the session. Please do complete that, as your feedback is very important to us. It's now my pleasure to introduce our speakers tonight. Denise Lyons has been a nurse for more than 38 years and began working in primary care 25 years ago. In 2012, she was endorsed as a nurse practitioner and currently works in general practice in Newcastle. Denise is passionate about health promotion and disease prevention in our community. Dr. Sally Sweeney is a general practitioner at Ellamore Vale General Practice in Newcastle and is also at Family Planning New South Wales, where she has been the medical coordinator at Hunter Clinic since 2016. Sally is a clinical instructor across all Family Planning New South Wales education courses and joined the Family Planning New South Wales Research Centre in 2019, with several peer-reviewed publications in the area of sexual and reproductive health, including cervical screening. Thank you, Denise. I would like to ask you to start our presentation today. So let me just give you, there we go.
Thanks, Sandy.
My pleasure.
There, can you see my slides okay?
Beautiful, thank you.
Excellent, okay. Thanks everybody for tuning in tonight to this session. I feel pretty lucky to be co-presenting with Sally, who's we all know has been a real expert in our region in women's health for a long time. My job is going to be the first half, talking a bit about the changes that were recently brought in, and then Sally will take over during the second half. So let me see if I can move my slides along. Now they don't want to. They did just before we practiced. Oh, they are. I would also like to acknowledge country and recognize the traditional custodians of the land and sea on which we live and work, and pay respects to elders past and present. So the learning objectives for tonight, we're going to want to make sure that by the end of the session tonight, everybody's aware of the new self-collection eligibility policy that changed on the 1st of July. And discuss the self-collection exclusions according to the National Clinical Guidelines. And then Sally is going to talk about what changes were made to the intermediate risk clinical pathway in February 2021, including changes to referral recommendations. So probably most people online would be aware that's referring to people who have the result that comes back from pathology lab saying HPV non-16-18. So a little bit of changes there. And then being one of the health pathways cheerleaders, I also would hopefully be able to talk to you for a minute about the appropriate referral pathways and where you can find that information on health pathways. Just a bit of a disclaimer up front here. Although we refer to women in this presentation, cervical screening is relevant for anyone who has a cervix, including trans and gender diverse people. Okay, it's like, now you guys know that whenever you're practicing, everything goes perfectly well. And then when you go to do the thing, it just doesn't go. Anyway, there's the next slide. There you go. So just firstly, I'll give you an overview of the National Cervical Screening Program, highlight the changes to self-collection eligibility, and then practical aspects of offering self-collection. Sally is going to go through some case presentations, and then we'll have some questions and answers. So where are we up to now? Everyone will remember just a few short five years ago, in 2017, we went from 2 yearly Pap tests that we've been using for, what, 30, 40 years, to do cervical cancer screening, changed over to that new system, the 5-yearly cervical screening test, a test for HPV virus. As we know, the HPV virus is the cause of cervical cancer. So at that time, self-collection option was introduced. It was only an option, however, for people who were underscreened or never screened. And at that time, we also started increasing our language around co-test and LBCs and all the different terminology we all got used to about 5 years ago. In February 2021, so just around a year and a half ago, there was a change to the intermediate risk recommendations, so where HPV non-16-18 is detected. And then in July this year, the introduction came, the change to self-collection eligibility. Now on the left-hand side of the screen, the changes to the National Cervical Screening Program guidelines. There is a lot of information online. Hopefully, between this presentation and what we've done to update health pathways and also that link to that website, you'll find all the answers that you need in relation to the new screening guidelines. So just a bit of background first about cervical cancer. It is the 4th most common cause, most common cancer and cause of cancer deaths in women worldwide. Unfortunately, as with many health conditions, it's not an equal spread across the globe, and the burden is certainly greater in low and middle income countries, and that's very much related to the lack of access to screening in those countries. Nearly 90% of the deaths in 2018, according to the World Health Organization, were in women in low and middle income countries. So it's definitely something that we can improve with better screening. So in Australia, we're doing fairly well. Australia is in fact on track to be the first country to eliminate cervical cancer, hopefully by 2030. We don't have we have less deaths now than in the past. So in 2021, 913 new diagnoses and 237 deaths. I was about to say only and stop myself because, you know, one death from a disease that can be recognized early and treated is one too many. And in Australia, just as globally, there are inequities in the current program, and those are related to socioeconomic status, remoteness, and Indigenous status. So the current rate of screening in Australia is about 52%. The target that the World Health Organization has set globally is 70% of women screened for HPV at least twice in their lifetime. In Australia, the vast majority of women who develop cervical cancer are under or never screened, just also what goes on in the rest of the globe. So self-collection, it's very exciting. It provides an opportunity to reverse this decline in overall screening participation rates, and, you know, even up the inequities that we see in participation. So, and it is definitely, screening is the key enabler to eliminating cervical cancer. So roughly, some references that you read say 72%, some say 80%. So somewhere between 72 and 80% of the cervical cancer patients in Australia are never screened or underscreened. And so the groups that have been identified as being more likely to be underscreened or never screened include, of course, Aboriginal and Torres Strait Islander women and women from culturally and linguistically diverse backgrounds, and including sometimes those women who have experienced female genital mutilation. These patients may prefer to access screening from migrant and refugee services who have a lot of experience working with that population. But we also know that people who identify as lesbian or bisexual who are same-sex attracted, and people who identify as transgender and who still have a cervix, people who have experienced sexual assault or abuse, women who experience sexual activity or abuse early, and women with a disability, all fit into the category of groups of people who are less likely to have been screened. So just to remind you about the screening recommendations, cervical cancer screening is recommended for all asymptomatic women, including pregnant women with a cervix, who are aged 25 to 74 years, who have ever been sexually active, including those who have had intimate sexual skin-on-skin contact, those who have sex with women. In fact, ACON set up just to I guess increase access and increase education. They've set up a website. If you use hashtag the Inner Circle AU, there's some good videos on YouTube that speak directly to people who identify as male or non-binary, or also women who have sex with women. But also, screening is also recommended for people who identify who are no longer sexually active, those who have been vaccinated with the HPV vaccination, those in a monogamous relationship, and even those who use condoms. The recommendations now recommend starting screening at 25 years for most people. We'll go into some of the exceptions in just a minute. And the screening is every 5 years if oncogenic HPV is not detective. The guidelines also recommend that we invite asymptomatic patients who are older than 70 years to have an exit test and to discontinue screening if that is negative for HPV. Again, there are a few little more things here, so additional considerations, we'll call them. So for people who have experienced sexual activity or abuse at a very young age, before 14 years, a single screening test can be considered for asymptomatic patients between the ages of 20 and 24 who did not receive the HPV vaccine prior to exposure. Women who are immune deficient need to be screened more often, so every 3 years if they're HIV positive or solid organ transplant recipients, if they have a primary immune deficiency or they're on immunosuppressant medications for autoimmune disease, or if they are allogenic bone marrow transplant recipients treated for graft versus host disease. So just, I think it's a good idea to run a query in your practice database to see who you've got on immunosuppressant medications, and just make sure that their screening interval and reminders are marked as more frequently than the every 5 years. That would be the default, I think, that most of us put into our recall and reminder systems. DES exposed patients. So for patients exposed to DES in utero, the recommendation is for an annual co-test and colposcopy of the cervix and vagina forever, really. So daughters of women exposed to DES in utero do not have an increased risk of cervical cancers. They should be screened with routine testing at 5-year intervals, just like most of the population. Pregnant patients. Pregnant women can have cervical screening at any stage of their pregnancy, if they're due or overdue, and they can be offered self-collection, as this provides a really good opportunity for screening patients who may not be screened because of barriers related to the speculum exam. If it's a physician or a clinician, I should say, collected sample, the cervical broom is recommended, but not the endocervical brush. So there are a lot of potential barriers, emotional and cultural barriers, and the option of self-collection can address some of these barriers, not all of them, but hopefully it is a way of removing or addressing some of the barriers. And we will talk about some strategies around collection, where, when, who, and how. That also hopefully will address some of the barriers to collection. There's also, besides the emotional and psychological barriers, there are also practical barriers that can be addressed with self-collection. So people are busy, they don't get around to it. might cost a bit to go and have the test done. There can be transport issues, weight or mobility related issues, or just the clinician who they prefer to work with them on screening activities is, not available for some point in time. So again, hopefully self-collection will address some of these barriers and enable the ultimate goal, which is higher rates of screening. There's also barriers in knowledge. So some women don't understand the purpose of the screening test or the role of screening in prevention, the risk that cervical cancer is to them, who needs to be tested, how accurate it is, and really, I think a lot of people still in the community, just from talking, socially, a lot of people still don't know that self-collection is an option. So hopefully, the big answer that's going to enable a lot more screening is self-collection. It's a game changer. That's what we're hoping. And there's been some evaluation studies already done, and most screening participants described that experience of self-collection very positively and reported a greater sense of control over their health, which is something that autonomy and self-efficacy is something that we're always aiming for. So this is a great option for many people. The sensitivity, it's reassuring, I think, to us as clinicians to know that the sensitivity of HPV PCR testing from a self-collected sample is very similar for clinician and self-collected samples. So we're not trading good care by allowing patients to do the self-collected and encouraging them to do the self-collected when it's an appropriate patient client. So suitability for self-collection. Self-collection is not suitable if the patient requires a co-test. So just remembering the people who do require a co-test are going to be anybody who's symptomatic, so they're having abnormal bleeding. If they're having a test of cure follow-up for high-grade changes, if they're having follow-up after screen-detected abnormalities like glandular abnormalities after colposcopy, if they're been treated for adenocarcinoma in situ, so AIS, again, back to the previous slides about DES exposure in utero, if they've had a total hysterectomy with past history of high-grade lesions, they would not be suitable either. So everybody else is suitable, which means we can explain the procedure to women and explain that the self-collected sample is taken from the vagina, not the cervix, and it can be tested for the presence of the human papillomavirus, but we can't do any testing of looking at how the cells look. So no cytology or cells from the cervix abnormalities. So where self-collection is chosen, patients attending an in-person consult should be encouraged to collect their sample while they're still at the clinic. As I guess there's more of a chance of follow-through. It'd be the same if you're asking them to collect a urine sample. You're probably more likely, or a respiratory swab, you're just probably more likely to have that happen if you do it while they're there with you. Just noting that a clinician can assist the collection of a swab if a person has physical limitations like a tremor or low vision or another disability, and still classify it as self-collected on the request form. So the aim is to maximize participation in the screening process. So it's important to highlight that self-collection can occur in any setting, as long as the clinician who's working with the patient and explaining the procedure feels like that's appropriate. So that includes in the context of a telehealth consultation. You would, of course, have to work out the logistics of ensuring that they have the right swab and that the sample is collected accurately, I guess, and that swab then gets to the pathology lab. But A good example of this might be where somebody does have a disability and access is an issue, and they might have someone who's assisting them with their activities of daily living, who would be able to collect a swab from somewhere, and the patient could collect the specimen and then it could be dropped off at a pathology lab. So that is possible to do it that way. So it is an option for all who are eligible. Again, women and people with the cervix, age 25 to somewhere between 70 and 74, who have been sexually active. And the swab is a test for HPV DNA. So we're going to use the red flock swab, dry swab from the lower vagina, and no need for a speculum. So the speculum goes out, and I think that's a barrier for a lot of people. So hopefully this is, people will perceive this as more comfortable and I guess less, potentially embarrassing or invasive. So since the HPV virus is being shed from the cervix, it can be found on the vaginal walls. It is, again, not a cervical sample, so the pathology lab cannot perform reflex liquid-based cytology or any really assessment of the cells, the cervical cells from that sample, just the HPV DNA. So you can download instruction sheets, you can order them from the National Cervical Screening Program in sort of tear-off pads that explain exactly how to collect the specimen, just showing women about inserting the swab and rotating around the vagina a couple of times and then putting the swab back into the swab holder, the tube, and then it's hopefully labeled ahead of time. Hopefully you've stuck that label on there before sent them off to the toilet. And then that can be sent to the pathology lab for HPV testing. Now there also is the clinician collected sample that still will be an option for many people who choose it or people who need the healthcare provider collect sample for clinical reasons. And so you could even have both of these sheets printed off and can show them that you show the different option and explain the different option to women. When you or the GP fill in a pathology request form, you need to indicate if the sample is self-collected or clinician collected. And if it's clinician collected sample for cytology, so if I'll just go into it in a few minutes, but if HPV is detected on a self-collected swab and there needs to be an assessment of cells, so liquid-based cytology or LBC, then you'll have to call the patient back in, collect using the traditional method of speculum and cervical cells sampling, and then you would write LBC only on there. Be good if you can indicate if the patient is Aboriginal or Torres Strait Islander and any other relevant past screening information, any symptoms, relevant medical history like immunosuppression that we talked about earlier. So just jumping back into the results. With a self-collected sample, if the patient tests negative for HPV DNA, then they can just be rescreened in 5 years. If they test positive for other oncogenic HPV types, so non-16 or 18, aka intermediate results, they sometimes will have to that's going to be about 6 to 8% of those people who are tested. So those women will need to be recalled for a clinician collected sample for the liquid-based cytology. And then we go from there. On the next slide, I'll show you what happens with their result. If they test positive for HPV 16 or 18, they are referred for colposcopy. This is expected to be around 2% of those attending for routine screening. And then the cervical sample for liquid-based cytology will be taken at the time of colposcopy. So just the risk categories, and this will become more clear when Sally does her bit of the presentation too, but if it's HPV non-16/18 detected from a self-collected test, we can't really determine their level of risk until the liquid-based cytology is performed on a clinician collected sample. So that's the indication where you'd have to get them back in and do a speculum exam and collect a cervical sample. If that result, the liquid-based cytology result, is probable or high-grade lesion or glandular abnormality or invasive disease, they're going to be referred for colposcopy. If it's low-grade changes or negative, then they fall into that intermediate risk result, and they're going to have a repeat HPV test in 12 months. Again, if that's not really, really clear, Sally's going to make it really, really clear when she does her talking. In case studies, it will make it a lot more clear. I guess the main thing to understand is just if their test comes back, I guess, positive or shows the presence of HPV DNA, they will have to come back for a clinician collected sample, but that is going to be a minority of people. So just going back to that previous slide, that's expected to be 6 to 8% of people who have self-collected. There is a whole flow chart. So sometimes really hard to remember what about this and what about this scenario, that scenario. So you can access this flow chart online. So just this is a great opportunity to talk with patients, women who are presenting. And when you talk about all the other screening, skin checks, breast screen, colonoscopy, all the screening, to make sure that they're aware and can make an informed choice about their cervical screening. The option is now available for self-collection if they're not in one of those groups that are not appropriate. And you can discuss the pros and cons, including differences in management and follow-up, and then provide that step-by-step guidance in how to collect the sample and how the results will be received. Everything that I've just spoken about is summarized and accessible to you on the Hunter New England Community Health Pathways and also the Central Coast Health Pathways if you're calling in from that area. Hopefully everyone knows the login, HNE Health, and the password Pathways. It's on the right-hand side of your screen. If there's something that's missing when you go to the health pathway or confusing, there is a feedback button on the bottom of every health pathway, and we always really do appreciate feedback if we need to clarify something or add something or remove something. Remember too that it's really helpful. You can access a patient's previous cervical screening history because patients do move around a bit and sometimes they can't remember and we don't have a record. If you use best practice or medical director and Communicare, there is now an integration option with the National Cancer Screening Register. We have that at the practice where I work, and it's fabulous. It just links right in with our software, and we can pull up the patient's screening history with the click of a button. You can also access the National Register via PROTA. And if you need any help with accessing the National Register, you can ring the 1-800 number that I've listed there, or you can get in touch with your PCIO, which works for the Hunter New England Central Coast Primary Health Network. Every practice has a practice support officer. They used to be called practice support, and now I'm struggling with the name. It might be practice quality improvement. I can't remember. Sandy can tell us what PCIO stands for, but it's your phone a friend at the Primary Health Network, and they can absolutely help you with establishing this link or finding out what all kinds of great information you can get from the National Register, because you can also link to the Bowel Cancer Screening Register, and it's just really useful information to keep up to date with your patients and all their screening. So in summary, HPV testing with a self-collected sample is as accurate as HPV testing with a clinician-collected sample. You, as a clinician, an informed and educated and believing in patient empowerment clinician, can help your patient to make an informed decision by explaining the options and pros and cons of self versus clinician-collected sampling. Just remember that the cytology, looking at those cervical cells, cannot be done on a self-collected sample. So anyone who requires routine screening or follow-up on an HPV test after an intermediate risk screening result is eligible for self-collection. Anybody who requires co-test is ineligible for self-collection. And then don't forget the changes to the intermediate risk pathway that Sally is going to talk about. That's me. I'll just stop sharing.
Thank you so much, Denise. That's lovely.
What does PCIO stand for?
Primary Care Improvement Officer.
Thank you.
But essentially, you're right, your practice support, that person who comes out to your practice to support you.
That's
okay.
Perfect.
Sally.
Stop sharing. There we go.
All right, so my turn now. Okay, so just bear with me while I show my screen there. Okay. Oops, that's not what I wanted. Okay, can we all see that?
Perfect. That looks great.
Thank you. So what I'm going to do to follow up on Denise's really comprehensive, I guess, background there on the science and the data and the rationale behind it all, I'm going to take you through more of the practicalities of rolling out the self-collected pathway and some of those changes to the intermediate risk pathway management. Just to say that if you want to, I'm hoping that we'll have some time for some Q&A at the end. So as we go, some of you have already been popping some questions into the question box there. So on the little grey box, if you go down, you'll see questions in that drop-down box. As we go, if anything comes up that you have a question about or want more explanation, just pop it in there. And when we come to Q&A time at the end, we can go through and have some time to get to everyone's questions. Okay, so cases and practicalities. So our first case we're going to start with is 28-year-old Jonah. Jonah is under the care of a transgender multidisciplinary team. Jonah is a female to male transgender man, and he comes along to your surgery routinely for his regular testosterone injections. Now, your practice nurse has very diligently identified that Jonah, in fact, has no past history of cervical screening on the register, and you're using your software, and you've managed to integrate the National Cervical Screening Register into your software. And what that will do is if somebody's overdue for screening, you'll see in your software an alert that there's overdue screening. So that's been noted, and the nurse has called you in to check the testosterone. Have a think about what you might do next. It can be a bit daunting to have to suddenly, take that issue up with a patient who may not be familiar. Often you're just called in by the nurse to check an injection, but it's a really good opportunity to address someone who represents our underscreened population, who we know that cervical cancer tends to occur more in. So in managing Jonah, we need to be very mindful that sex and gender diverse people who have not undergone surgical removal of the cervix remain at risk of cervical cancer and certainly require screening. When managing these patients, we really want to take care to be using preferred pronouns. And a lot of the clinical software now, you can actually enter the preferred pronouns. So it's a good habit to get into when you're seeing a patient for the first time, to say, look, these are some routine questions I'm asking everybody. What is your preferred pronoun? Making a note of it so that you can be consistently using it. And also using preferred body terminology. So for transgender patients, they can have some preferences around what body terminology they're more comfortable with, particularly in a transgender male in referring to his cervix. It can be triggering and uncomfortable. So asking about how he would prefer us to refer to his cervix is an important step to take. We really do need to engage a trauma-informed approach with these patients and acknowledge that a clinical examination and acknowledgement of the fact that he has a cervix can be quite traumatic and triggering. It would be important at that encounter where we've identified that he has an unmet screening need to discuss it. We don't necessarily need to do it that day, but we can start the conversation. Kind of in the same way as we do with our smoking cessation. It's kind of like, okay, what stage of quitting are you at? It's the same sort of thing for you know, introducing the concept of screening. And using a shared decision-making approach is really important. And you may need to have the discussion over several visits and go, look, you know, we've identified that you are actually overdue and eligible for this screening. Here's some information to take away. Here's some information on self-collected screening. Maybe have a think about it, and when we see you next time, we can have more of a chat. So it's less confronting for him. And it's about offering the choice of self-collected screening. So this is all about just giving our patients choice. You know, do you want a clinician collect? Do you want to self-collect? And then making that informed decision. But certainly for patients like Jonah, the offer of self-collected screening can really close that gap and reduce some significant barriers. If in fact Jonah elected for a clinician collected sample, or if he was one of the small number of people who returned a HPV non-16-18 result and had to come back for a clinician collected sample, there are then some considerations to be had, because obviously it's one thing to have a self-collected sample, it's then a whole other thing to have to undergo a speculum examination. And particularly for patients on testosterone, that can cause some significant vaginal atrophy. So it would be important to consider a course of vaginal estrogen prior to a speculum examination for a clinician collected sample. And some of the feedback we've had from transgender clients is that you do need to be aware of some triggering trade names. So for example, Vagifem, because it's got the word fem in it, can actually be a bit triggering. So these are all of the things we need to be thinking of and being aware of. And for anyone who may be interested in further information about, you know, how we can resource ourselves and have our toolkit well ready for managing our transgender patients, there's a really fantastic website there that you'll see on the slide that you can access some excellent resources on. Our next case is 55-year-old Betty. Now, Betty is a regular patient of ours, and she has an intellectual disability. And she's never, ever been screened for cervical cancer. She's not currently sexually active, but we think there possibly has been some previous. She's now post-menopausal, and she comes in for a routine visit for scripts with her carer, and having sort of newly installed the screening register hub into our clinical software, we readily identify that she's never been screened. Now, what are some of the things that we could do to facilitate cervical screening for Betty? Now, just so that we're not all asleep, because normally if we were face to face right now, I'd be asking for a whip around the room. So if anyone into the chat box rather than the questions box wants to just type some strategies that they might have, that might they might have experience with working that they might use in their practice to help Betty, feel free to pop into the chat box to share with your colleagues, because it's a bit boring if you just listen to me talk about what's in our toolkit. You might have some really good ideas yourself there. So pop them in and we'll have a look at them. It's all right. I might keep going while you're talking through. So, some of you may be familiar with this resource. This is a resource that was put together a few years back now, a campaign that the health promotion pillar at Family Planning New South Wales put together. It was part of a campaign called Just Checking, and it put together a suite of resources around supporting people with an intellectual disability to access cervical, bowel and breast screening. And it's a suite of resources that's written in easy read language. It took a very consultative approach with the intellectual disability community. There were lots of consumer stakeholder involvement in putting this together. And there's one there called Betty's Story, and it's all about a client called Betty who's having a cervical screening test. Now, keeping in mind that this was put together pre-universal self-collection pathway, so it is very much geared towards a clinician collected sample and a speculum examination. But it's a really lovely resource. It's got illustrations, it's in the clinic. This is something that you can freely download.
You're freezing a little bit, Sal.
Yeah.
She might pop out and pop back in. Gosh, the internet.
Sally, you might try turning off your video, perhaps, because we can hear you perfectly. Well, we could hear you perfectly. Sorry, guys. And thank you, Julia, for sending through. You did send that through on the questions box. That's great. So when
Yeah, I think that's great, Julia. That's exactly right. I think you 100% discussed that self-collected samples versus clinician-collected samples with Betty to check understanding and preference. I would love to do a poll to see amongst the women who are listening in how many people would prefer self-collected to clinician-collected. I think a vast majority of people would probably prefer self-collected. So that's, I think, the going to be the preference for a lot of people. I did want to ask Cheryl about the comment that she put in the chat about doing a PAP for one of your patients, and he got a bill for the PAP as Medicare won't subsidize it as he did not identify with Medicare as female. So I wondered, Cheryl, if that was recent or if this was more than 5 years ago, because I know that Medicare have done some updates again where people's gender, and sexual orientation can be recorded with Medicare now. So for example, people who identify as not he or she, but they, that can be recorded. So I wondered, Cheryl, if that was quite some time ago or recent, because I think they've come along a bit with Medicare with recognizing diversity in that. That was just before the CST came in, so I hope it's sorted now, but I was mortified as hadn't expected it. Yes, I don't like, nobody likes our patients to get bills they weren't anticipating. It's a bit like if you do used to do the PAP test too soon, or even do the CST when that came in too soon, and patients would get a bill because the correct interval hadn't elapsed in between tests. But no, I think Medicare have improved their, had a bit of diversity training and have now made that an option. So hopefully that problem has been sorted. If we cannot get Sally back, which I hope we do, because she's definitely got a lot of expertise in this area. I do have a copy of her slides that we could bring up, Sandy, and go through. Hopefully she's going to jump back in a minute. Maybe if I share her slides also. Sorry guys about the technical glitch.
All right.
Yeah, I have Sally's slides here, so I might open them up and see if I can share them if my, let's have a look. If I can. Yep.
There you go. That's coming up. Thanks, Denise.
Yep, no worries. So now I need to go to give you guys a view that is the correct view. How's that? Let's see.
Great, thank you. That's looking good.
Okay. Hopefully Sally will rejoin us, at least with her brain and her voice, because otherwise I'll just be winging it to the best of my ability, guys. So with Betty, discussion over several visits. Yeah, I think it's, might take several discussions. And so what you can do is provide some easy read resources and offer the option of self-collected screening. You can show the swabs to Betty. I think this is true really for all of our patients, all of our women, to show her one of the swabs during consultation. And you can use picture resources to demonstrate where the swab goes and explain self-collection in simple language. Again, it is a shared decision making. You can assist Betty again in taking the swab if she's unable to manage it herself, and it would still be on the pathology request form, considered a self-collected sample. And just as long as, I guess the key understanding there in those discussions would be that there would be a need for clinician collected samples if there's a abnormal result on the self-collected sample. Okay, so the next case is going to be about Alex, a 32-year-old. Alex is a busy mom. I don't think there's any moms who aren't busy. And she's had a bad run of sick toddlers at home, and she can't get time off work to come to the GP as she has run out of sick leave. She has a telehealth appointment booked for her pill prescription, and you note that her CST is overdue. What do you do? So you can discuss cervical screening overdue CST opportunistically. Certainly, we hope, and I guess where your software is integrated with the screening, an alert will actually come up from the National Register that will remind you that she's overdue, and you can certainly present that self-collection as an option. The guidelines, again, do allow for flexibility around where the sample can be collected. So that enables us providers to develop models that will meet the needs of our communities. So as a clinician collecting the sample or discussing the collection of the sample, the clinician who writes the request basically is responsible for facilitating access to and return of the swabs. So that sometimes can be the tricky bit. Someone did put into the chat earlier that they were having a hard time accessing the self-collection swabs from their pathology supplier. You use the same swab. It is usually a red with like a fluffy end, a red tip swab. I wish I would have brought one with like a fluffy end on it. But most of them, Douglas and most of the big providers will give you those swabs, and they're the same ones we use for testing for chlamydia. Some of the smaller path labs might not be able to provide them, but they should be able to provide them for you. If you want a bit more information, you can go to that clinical guideline FAQ, but essentially you just need to understand that you can, it's quite appropriate for someone to do a self-collection at home. So appropriate to offer that self-collected screening via telehealth in whatever model works for local practice. Just remembering that the clinical governance around the result, they can pick up the swab from the clinic and do it at home and bring it back to the pathology collection center. They can go to a pathology collection center and use the restroom there and do it. Clinicians can organize an electronic request form to go to the pathology provider, or you could post the swab and the request form in an envelope. So lots of options there, and just different ways depending where you are and what's happening. So tricky follow-up, and this is Sally. The reason, I'll just go through these dot points and try to explain what the points that Sally was going to make. So sometimes the recommendation from the pathologist may be incorrect. So this is specifically in relation to the intermediate risk. So the HPV non-16, non-18, the recommendation used to be to repeat it at 12 months, and then at 12 months they would, if it was still non-16 or 18, they would be sent for colposcopy. But now the recommendation is that that's repeated again at 24 months, with exception. Oh, yay! Hi, you came just at the right time, Sal. Oh, Sally, I'm thrilled you're back with us. Can you hear me okay? We can see you. Sally, can you hear me? I think I can hear you, Sal. Can you hear us? So sometimes the recommendation from the pathologist may be incorrect, and that can be in instances where some clinical detail may have been overlooked or omitted from the request form. For example, for Aboriginal and Torres Strait Islander women, that's going to change their status because they're at higher risk. Their follow-up is different based on their Aboriginal and Torres Strait Islander status. So that was why when we talked about what information should be included on that request form, Aboriginal and Torres Strait Islander status is one of the things, because it does change what's happening with the follow-up. And by the same token, with immunosuppression that we talked about earlier in the presentation, they require the 3-yearly screening. So sometimes that doesn't, there's no automatic system or alert to that. It just really has to be included in the clinical details. Otherwise, it will be overlooked. Same thing with DES exposed women. Same thing if women are symptomatic. That needs to be people who have abnormal bleeding. As we discussed before, they need a co-test, and the clinical reason for the co-test, which is usually abnormal bleeding, would need to be documented on their pathology request form. Also, if they've had colposcopy, and you can record the results of those findings, that's great. Now, there is, hi Sal, can you hear me?
Hello, I'm back.
Yeah.
I'm so sorry. I didn't even know I'd gone. So I was sitting here talking to myself until I got a phone call that said, no one can hear you. So you missed all my best jokes. So anyway, so thank you for taking over, Denise. So
That's
where
okay.
are you up to now?
I'm nowhere nearly as efficiently as you, but I wonder, Sally, if your internet gives you trouble, if you want to
it's all right, I'm hotspotting from my phone now, so it's all
I was going to say, okay, I was going to say, if you give us your brain and your voice, I can do the the sharing.
That's all right. If you want to drive the slides, I'll do the talking.
Okay.
That's
So
perfect
we
now.
did talk about Betty with her disability and some strategies
Yep.
for that. And
Yep.
then we also did talk about what was her friend's name after that?
Oh, just start with D. I think it started with D.
Yeah,
The tricky
we talked
follow-up.
about. Oh, we just talked. She's a busy mom, the very busy mom, and
Yes.
and how we did talk about how you know, there she could, all the alternatives for maybe via telehealth, how we could organize it. So we worked our way through those, and then we came to the tricky follow-up slide and how
Fantastic.
yeah, so how important it is to write Aboriginal and Torres Strait Islander status and all the other clinical details that we talked about on that slide. But we got only so far as previous colposcopy findings and TZ type. So if you want to talk about that.
Yeah, sure. So the slide that's on the screen now, I think, is tricky follow-up. Have we gone through the case yet for that? No. Okay, so previous colposcopy findings. Yep. So these are all the things that are potentially going to influence follow-up. And sometimes if we haven't included some of these really critical points, the recommendation from the pathologist might not actually be correct. So if the pathologist writes back, follow up in 5 years, or repeat in 12 months rather than colposcopy now, or vice versa, it might not actually be the correct recommendation. So we really do have a duty of care to be making sure that we're including as much clinical detail as possible, and being able to integrate the cervical screening register into our clinical software has really made this so much easier, because with one click you can see the colposcopy history, you can see previous histology, you can see previous screening. So it makes it so much easier for us to have all of that information readily available. Noting Aboriginal and Torres Strait Islander status is critical, because with the updated intermediate pathway follow-up, it will change the recommendation depending on ATSI status. As Denise said in her talk, immunosuppression will require 3-yearly rather than 5-yearly screening, and if we don't include that, then the pathologist will just routinely recommend 5 years. Our DES exposed women, very small but significant group, do require yearly assessment, vulvoscopy and colposcopy for those women. Anyone with symptoms, we must note the presence of symptoms, and they'll be requiring a co-test. The previous colposcopy findings are very important, and I will talk more to that in the next slide. And just to know, some of you might be aware of the large COMPASS trial. That was a large international trial that was launched back in 2018, I think now. It was more at the time of the renewal to sort of compare cytology every 2.5 years with HPV screening outcomes. And it was tens of thousands of women who are still part of that study follow-up. But they don't appear on the National Cervical Screening Register. The COMPASS trial has its own register. So it's important to know whether someone is a COMPASS participant, because their screening history will need to be accessed from the COMPASS trial, and the website is there and there's a phone number that you can call. Slowly, as the trial winds up over the next year or two, transitioning all of their histories across to the National Cervical Screening Register, but at the moment they don't sit there. So take-home message, really important to carefully consider clinical history when giving follow-up advice, and don't just automatically go by what the pathologist has recommended on the report. So, oh, next slide. I forgot I'm not driving.
I got you. Rhonda.
Rhonda, here she is. So she's 56 and she had a CST in June 2020, which showed non-1618 HPV with a low-grade squamous lesion on reflex liquid-based cytology. So the recommendation at that stage was repeat in 12 months. She came back and had her repeat 12 months later, and again had the same result. So as at July 2021, we did have that change in the intermediate pathway that came in February 2021. And prior to that, automatically, after 2 non-1618s with a low grade, you would score a colposcopy. but the guidance changed as we got more safety data and confidence that for some women you could go a third before you needed a colposcopy. But for Rhonda at 56, do we think she needs, with that result, a colposcopy now, or can she go for another 12-month repeat? And at this point, if we were in real life, I'd go, put your hand up. And anyway, think about what your answer would be. And we'll go to the next slide, Denise, and all will be revealed. This is just a little algorithm for the current intermediate pathway management, and this has been in effect since February 2021. And the grey box here is really important for our case. So we can see here that you come through and you have your HPV non-1618 number 1 with either negative or low-grade LBC. You come back for another one in 12 months. If it's the same again, then you can come back for another one in 12 months, except what that grey box there says for women over 50, Aboriginal or Torres Strait Islander women, or women whose index screen was overdue by at least 2 years. So that's important. Next slide, please, Denise. So what this means for Rhonda is that because she's over 50, she needs a colposcopy now. So she was sent for a colposcopy after that July result. The colposcopy was normal. You've got a letter back from the gynecologist who said she had a type 3 transformational zone and to repeat the HPV test in 12 months, please. So you very diligently add a reminder.
Can't hear you. We can't hear you. Oh no. Stop. Stop, Sal. Oh no. Oh goodness gracious. Something happened.
Yeah, sorry, Sally, and she doesn't know that we can't hear her.
This is one of those presentations that's like, what else can go wrong?
Yeah.
Sally, we can't hear you. I wonder if you turn your camera off, Sal. Can you hear us? Oh my goodness. Goodness gracious. Well, what advice do you give Rhonda? I might turn the page and reveal. So, just a bit about the, on the last slide, I'll just go back to the last slide, and that reference to, golly, the endocervical component. Sally. So the recommendation depends on transformational zone type at colposcopy. So there are the transformational zone types. If type 3 at colposcopy with HPV detected at 12 months, then repeat colposcopy is indicated. The recommendation to repeat the test in another 12 months would have only been correct for type 1 or type 2. And you're really only going to know that from your colposcopy report. So just to highlight that it's just please always include all the relevant clinical detail that you have, including colposcopy findings and Aboriginal and Torres Strait Islander status on the pathology requests. Now, all of this information, just to say it again, is also highlighted.
Can you hear me there, Denise?
Yes. Yeah. Yeah.
Oh, beautiful.
Yeah. So
right.
this
Sorry.
yeah, so this that's okay. We're still talking about Rhonda, and we were
Yep.
just looking at the different transformational zone types, 1, 2, and
Yes.
3. So that's the slide I've got up there now.
Yeah. So that's super important to determine what Rhonda's follow-up's going to be, because if the colposcopist had reported that she had a type 1 or a type 2, meaning that they could visualize that transformation zone where the cells that get changes are, then it would be quite okay for Rhonda to repeat in 12 months. But because she had a type 3, meaning that those cells were hidden up in the canal and the colposcopist probably couldn't see them all very well, in fact, the recommendation is going to be that she needs a repeat colposcopy now rather than a repeat HPV test in 12 months. And if we go to that next slide there, Denise, just there's a little link there, that website there takes you to one of those nice little colourful algorithms that takes you through those recommendations about what the outcome is depending on the transformation zone. And again, if you are, so say you were requesting Rhonda's repeat CST after that colposcopy, when you look at the information in the register that you can link into your software, the colposcopist should have actually entered what the transformation zone was at the time of the colposcopy, and you should be able to see that there. If they didn't necessarily write it back in their letter to you, they at least should have put it up on the register so you can see it. So it's often helpful when you're writing the request form for the follow-up HPV test to note what type transformation zone it was. Although that said, the pathologist reporting should have access to that information as well. So in summary for Rhonda, the recommendation does depend on the TZ type at colposcopy, and if it is a type 3 with HPV detected at 12-month follow-up, then repeat colp is indicated rather than to repeat in 12 months. And that would have only been a correct recommendation if she'd in fact had a type 1 or 2 TZ. So again, it just demonstrates how important it is to include all of the relevant clinical detail, previous colposcopy findings, ATSI status on pathology requests, and consider all of this when interpreting the pathologist's recommendations. Next slide. So what's our role in primary care? So as Denise already said, Australia is on track, excitingly, to be one of the first countries to eliminate cervical cancer. And the modelling is telling us that that will be by 2035. However, currently only 62% of eligible people are participating in the National Cervical Screening Program. And 72% of those diagnosed with invasive cervical cancer are in fact under or never screened. So if we're going to achieve that elimination goal, it's these underscreened women, underscreened people that we need to be targeting and bringing into the screening program to reach that target. So the WHO has set out some 2030 control targets, and this sets out 3 things. It's the 90-70-90 target. So it looks at having 90% of people HPV vaccinated by age 15, 70% of eligible people screened with a HPV test at age 35 and 45, and 90% of women with cervical disease receiving treatment for their precancerous or invasive lesions. And when you think about our role in primary care, we're integral to each of those 3 things. You know, primary care gets a bit of a bad rap sometimes, and we're in a bit of a, you know, a reputational spot at the moment, but primary care really has an opportunity to really be integral to achieving the elimination of cervical cancer in Australia, because we have an important role in offering catch-up HPV vaccination and identifying which of our patients might have missed out on their HPV vaccination and offering catch-up. We have an integral role in delivering the screening and identifying those under and never screened women. And we offer the referral pathways to help ensure that women with cervical disease are receiving treatment. So we are integral to achieving this, and that's going to be a real legacy to our generation in general practice. Next slide, please, Denise. So how can we support your practice to optimise cervical screening? So first step is to know the guidelines. And there was a bit of a sneaky website change. It used to be on this wiki platform, but now the guidelines sit with all of the other Cancer Council guidelines. So the website itself did change, slightly more user-friendly, but you've still got to trawl around a bit sometimes to find what you want. But that's the new guideline website there. Know what your self-collection devices are from your local lab. So some, you know, we've all probably got
Goodness gracious. I mean, Sally has so much enthusiasm for this subject and so much expertise for this subject, but it just seems the internet gods are just not wanting it to happen. So I'm going to carry on. Know your lab requirements. I think in our region, we did make a phone call. All the pathology labs in the Hunter region are processing these, but know your lab requirements. You know, find out what swabs they can provide. Use that provider portal and integrate with your software. It just makes the job so much easier. You recognize underscreened people in your practice. Consider a practice audit. You know, most practices now do 1 or 2 or 3 or 4 quality improvement activities because there's a practice incentive payment related. And so your practice quality improvement officer, your PCIO at the primary health network can help you if you're interested in doing a specific quality improvement activity around identifying never screened and underscreened people who are on your practice database. They can do that using, you know, the Penn Clinical Audit tool. Or other practice software, you can just pull it right out of the database. So, yeah, so doing a recognition and then, you know, developing some method for doing active recalls. You can continue to do opportunistic screening, adding self-collection as an option for patients, and just have the swabs and the written resources available to demonstrate with patients. Let them have a look at the swab, show them the pictures that I showed you. You can order some of those tear-off pads that have the self-collection advice, you know, on them that you can provide to patients. So lots of resources that are available for you to have those shared decision-making conversations. And here's the links to some resources. If you go to the National Cervical Screening, just Google National Cervical Screening program, it will take you to the healthcare provider toolkit, and you can download a lot of resources, patient education and clinician resources there. The GPX has a clinical education course that you can do, the VCS Foundation, and then your pathology lab probably has some resources that are available to you as well. This is an example of one of the resources that came from VCS Pathology. Yeah, that shows you, that can help with that shared decision-making conversation, the differences between the clinician collected sample and the self-collected sample. They both identify HPV, but again, the liquid-based cytology, as we've previously talked about. It also lists on there who's an exclusion or excluded from self-collection, so that's helpful to have in writing. And you can download that as a PDF from the link below. So now it's time for questions, and I did see a question pop up. Wondering how people bring up the DES immunosuppressed topic. Do you have a list that you show patients when questioning them, or do you add into your list of questions specifics regarding this? So myself, when I'm doing cervical screening, I do ask those questions. You know, is there a history of DES exposure in utero? Are you on any immunosuppressant medications? So for me, I've got a little shortcut in best practice we use, and it just gives me my question prompts that I want to ask women every time we are doing a cervical screening consultation. So laboratory pathology need the red top self swab swirled in thin prep before sending to the lab. and you also send the swab in its plastic tube. So my recommendation would be that some labs will have their own instructions for you. So just whichever pathology company you are working with most closely, get in touch with them and ask them. Thank you for that, Penny. That's good to know. So yeah, so there are people online who've sent messages. Some are with Douglas, some are with Laverty, some are with SIDPath. So different labs will have different procedures. So yeah, the best thing to do is just be really familiar with and ask them if they have any resources to support you in having those self-collection conversations. Are there any other questions? I don't see any other ones that have come up. Sally, we did cover the last couple of your slides and answered just a question in relation to how to ask about DES and immunosuppression. I don't even know if Sally can hear us.
She's having difficulty actually hearing us.
Yeah, I think so. Well, look, it is 7:45. There are no more questions in the chat. And so I think it's gonna be one of those nights where we all get to have an early mark because yeah, the gods of the internet have just not willed this to be perfect tonight. But hopefully, I'm hoping everyone who is present, got some good information from the session, and that all 45 of you who are still online with us will we'll hopefully leave this evening with a bit of a increased understanding. Again, if you have questions, please, the PowerPoint presentation will be available on the PHN education site, as will a recording of this slightly clunky presentation.
It will.
You might just want to go to the PowerPoint.
I think
all the
Sally
links.
can actually hear us again now.
Yeah, I can see you now, Denise.
Oh, awesome!
Yes,
but I do think,
and we can see you, Sally, now.
Oh,
that's
good.
Awesome.
So between Health Pathways and the links in the PowerPoint presentation and the link to the Cancer Council cervical cancer guidelines, hopefully all of your questions will be answered, and you'll feel really confident to have these conversations, and we can get those screening rates up.
Awesome.
That's enough out of me, Sally. You got anything to say?
Thank you so much to both of you, and particularly Denise. Thank you for stepping in. That was really great. You did an awesome job.
Thank you, Denise. I'm so sorry. I don't know what happened. It was telling me I was connected, and
that's okay.
That's okay.
This stuff happens. It's good. Your slides were awesome, Sal.
All right. Well, thank you everybody for joining us, and thank you for hanging on there. And thank you for sending through your presentation, to your questions. That is awesome. And I'm sorry about all the issues with the technology and the internet, but you're consummate professionals in dealing with that. So thank you so much, both of you. All right. And so it just remains for me to say goodnight to everybody, and please have a wonderful evening. And thank you for joining us again. All right. Thanks, everybody. Good night.